Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 281 of our Pharmacotherapy MCQ series, which majors in dyslipidemias, atherosclerosis and coronary heart disease. The first question reads, BCC is a 46-year-old perimenopausal white female who has recently relocated to the area and is establishing care with a gynecologist. As part of her annual evaluation, a routine lipid panel is obtained. She takes no prescription medications but does take a number of dietary supplements and vitamins, including krill oil, multivitamin B complex, and vitamin D. She has no history of tobacco use, hypertension, or diabetes. She states she was told a number of years ago that her LDL bad cholesterol was elevated, but her HDL good cholesterol was high and no treatment was indicated. She has enjoyed jogging and spin classes but says that as she gets older she is more fatigued and sore with exercise. She follows a Mediterranean-style diet and has a glass of red wine daily. Her father is alive at age 72 and takes statin therapy for hyperlipidemia, though she is uncertain of the severity of his lipid disorder. He has no history of cardiovascular disease. Her mother is a 71-year-old diabetic and underwent coronary stent placement last year following the onset of angina and an abnormal stress test. She was started on statin therapy at the time of her procedure. Her brother is overweight, has hypertension and borderline diabetes, and is also on statin therapy and fenofibrate. On physical exam, the patient has the following. She is normotensive, that is 128 systolic, 76 diastolic. Carotid pulses with normal amplitude and no brutes. 2/6 crescendo, decrescendo noted at the left sternal border. No abdominal brute, peripheral pulses 2+, no tendon xanthomas, corneal arcus, or xanthelasmas. Following a 12-hour fast, the patient's lipid panel shows the following results. Total cholesterol is 290 mg per deciliter. HDL cholesterol is 56 mg per deciliter. LDL cholesterol is calculated at 218 mg per deciliter. TG is 132 mg per deciliter. So my question to you is, what is your assessment of BCC's lipid panel results? The NLA recommendations for patient-centered management of dyslipidemia were published in 2014. Similar to NCE-PATP3 guidelines, these comprehensive recommendations for management of a variety of dyslipidemias continue to recommend lipoprotein targets, non-HDL cholesterol and LDL cholesterol, and titration to achieve goals of therapy. The patient's LDL cholesterol is very high and she would qualify for statin therapy as defined by both the ACC, AHA and NLA recommendations for management of hypercholesterolemia. Her HDL cholesterol is near the average range for a woman and her TG level is considered normal, that is below 150 mg per deciliter. There has been a misconception among some providers and patients that a normal or high HDL cholesterol level is protective, in the presence of hypercholesterolemia, based on a total cholesterol to HDL cholesterol ratio of less than 3.5, and that statin therapy is not indicated. However, in the presence of very high elevations of LDL cholesterol levels, all current and previous guidelines recommend statin therapy regardless of baseline HDL cholesterol. In the presence of very high LDL cholesterol levels, it is important to consider a number of issues prior to initiation of therapy. The patient's lifestyle, including diet and exercise, may play an important role in BCC's new diagnosis of dyslipidemia. However, she is actually quite compliant with lifestyle recommendations for optimal cardiovascular health, and this is unlikely to be a factor in her lipid levels. Careful review of family history of hypercholesterolemia and atherosclerotic cardiovascular disease, abbreviated as ASCVD, by construction of a detailed pedigree can identify patients with possible heterozygous familial hypercholesterolemia, abbreviated as HeFH, or homozygous familial hypercholesterolemia, abbreviated as HoFH. BCC's father has dyslipidemia of uncertain severity and is on statin therapy, but he has no history of premature atherosclerotic cardiovascular disease. Her mother developed atherosclerotic cardiovascular disease after age 65 and a long history of diabetes. Statin therapy was not prescribed until her stent placement, and familial hypercholesteremia is unlikely. Her brother has a mixed dyslipidemia, most likely exacerbated by overweight and poorly controlled diabetes. Thus, based on this brief pedigree, the diagnosis of familial hypercholesteremia is unlikely. Classic physical examination findings of tendon xanthomas, corneal arcus before age 45, and xanthelasmas are often, but not always present in familial hypercholesteremia. BCC does not have these findings. The patient does have a systolic murmur on cardiac examination, which may be indicative of aortic valvular disease, a very common problem in patients with homozygous familial hypercholesteremia. Mean total cholesterol is typically lower in premenopausal women than in age-matched men. Premenopausal women have a less pro-atherogenic lipid profile with higher HDL cholesterol levels, that is an average of 10 mg per deciliter, and lower LDL cholesterol and non-HDL cholesterol levels than age-matched men. Due to the hormonal alterations during the perimenopausal period, LDL cholesterol levels rise and are often higher than in age-matched men. Postmenopausal women also have a higher incidence of high TG and low HDL cholesterol levels, with an increase in small, dense LDL particles. It is not uncommon for women without a prior history of dyslipidemia to be newly diagnosed in the perimenopausal period, and BCC may be just such a patient. The next question reads, is there any evidence for other potential causes of BCC's dyslipidemia? As a routine, every patient with dyslipidemia should be evaluated for secondary causes of elevated LDL cholesterol, non-HDL cholesterol, or TG. Conditions that may be associated with lipid abnormalities include diabetes, chronic kidney disease and nephrotic syndrome, obstructive liver disease, hypothyroidism, anorexia nervosa, polycystic ovarian syndrome, and pregnancy, among others. Average values of total cholesterol, LDL cholesterol, HDL cholesterol, and TG steadily rise throughout pregnancy and levels peak near full term. In uncomplicated or normal pregnancies, neither total cholesterol nor TG exceeds 250 mg per deciliter at any time during pregnancy. A number of drugs are associated with dyslipidemia or worsening of baseline lipid abnormalities, including exogenous estrogen and progesterone therapy, and a careful review of the patient's medication regimen is necessary prior to initiation of lipid-lowering therapy. BCC is currently perimenopausal and does not take any medications associated with exacerbation of dyslipidemia nor any form of exogenous hormone replacement therapy or oral contraception. The next question reads, further review of BCC's laboratory studies showed the following. Glucose levels of 92 mg per deciliter. Alanine aminotransferase ALT levels of 24 mg per deciliter. Aspartate aminotransferase AST levels of 18 mg per deciliter. Creatinine levels of 0.9 mg per deciliter. Thyroid stimulating hormone TSH of 57 international units per milliliter. Laboratory evaluation has revealed that BCC's fatigue and muscle soreness are likely due to hypothyroidism, which has also exacerbated her previous dyslipidemia. She is placed on thyroid replacement therapy, and with normalization of her thyroid function, her follow-up laboratory results show the following. TSH is 1.254 international units per milliliter. Total cholesterol is 215 mg per deciliter. HDL cholesterol is 59 mg per deciliter. LDL cholesterol calculated at 132 mg per deciliter. And a TG is 118 mg per deciliter. So my question to you is, what is the next step in the evaluation of BCC's atherosclerotic cardiovascular disease risk? BCC has no other atherosclerotic cardiovascular disease risk factors or risk equivalents other than mild dyslipidemia. Using the ASCVD pooled cohort equations or cardiovascular risk calculator, her 10-year risk of atherosclerotic cardiovascular disease event is 0.9%. According to both the ASCVD and NLA recommendations for lipid management, there is currently no indication for initiation of statin therapy. The 2015 Standards of Diabetes Care of the American Diabetes Association (ADA) were revised to recommend initiation and intensification of statin therapy, high versus moderate, in patients with diabetes based on the individual patient's risk profile. However, the ADA notes that the presence of diabetes confers significant risk of atherosclerotic cardiovascular disease, and that the ASCVD cardiovascular risk estimator is of limited use in diabetics. Recommendations are made for patients 75 years of age for moderate or high-intensity statin therapy in the presence of atherosclerotic cardiovascular disease risk factors or overt atherosclerotic cardiovascular disease. The 2013 Clinical Practice Guideline for Lipid Management in Chronic Kidney Disease, abbreviated as CKD, published by the Kidney Disease Improving Global Outcomes, abbreviated as KDIGO panel, notes that in non-dialysis-dependent chronic kidney disease patients the relationship between LDL cholesterol and atherosclerotic cardiovascular disease events is weaker than in the general population. This is likely related to lipoprotein metabolic abnormalities characterized by lower levels of LDL cholesterol, elevated LDL cholesterol, an increase in small dense LDL, reduced HDL cholesterol, and elevated TG. Therefore, according to KDIGO guidelines, the measured LDL cholesterol may be less useful as a marker of coronary risk among people with advanced non-dialysis-dependent chronic kidney disease and does not serve as an indication for pharmacologic treatment. Instead, therapy is guided by the absolute risk of coronary events based on patient age and stage of chronic kidney disease or estimated glomerular filtration rate (eGFR). Specific doses of individual statins are recommended for each stage of chronic kidney disease or eGFR, and dose titration is not indicated. Statin therapy or combination therapy with statin and ezetimibe is not recommended in adults with dialysis-dependent chronic kidney disease due to lack of evidence of atherosclerotic cardiovascular disease risk reduction in patients with stage 5 chronic kidney disease. However, therapy may be continued in patients already receiving therapy at the time of initiation of dialysis. The next question reads, SOW is a 51-year-old African-American male with chronic kidney disease due to polycystic kidney disease. He has no history of tobacco use or diabetes, but is treated for hypertension. He is very active and works in landscape maintenance, but does not have a program of consistent aerobic exercise. He follows a heart-healthy diet consistent with the DASH, which is an abbreviation for Dietary Approaches to Stop Hypertension, recommendations, and has maintained a normal BMI. He is referred for nephrology consultation and the following results are obtained. eGFR of 42 ml per minute. T/C of 187 mg per deciliter. HDL of 39 mg per deciliter. LDL cholesterol calculated at 102 mg per deciliter. TG of 230 mg per deciliter. Hemoglobin A1C of 6.8%. BP of 126 systolic 68 diastolic. What is your assessment of SOW's atherosclerotic cardiovascular disease risk and his lipid panel results? SOW has stage 3B chronic kidney disease defined as an eGFR between 30 and 44 ml per minute per 1.73 meters squared. According to the NLA, recommendations for patient-centered management of dyslipidemia, patients with stage 3B to stage 4 chronic kidney disease are at high risk for atherosclerotic cardiovascular disease and should be considered for drug therapy. Statin therapy with or without ezetimibe are recommended therapies in chronic kidney disease patients who are non-dialysis dependent, and the goals of therapy are non-HDL cholesterol less than 130 mg per deciliter and or LDL cholesterol less than 100 mg per deciliter. The 2013 ASCVD blood cholesterol guidelines do not consider chronic kidney disease as a risk factor in atherosclerotic cardiovascular disease risk assessment and do not provide specific recommendations for statin or ezetimibe therapy in non-dialysis dependent patients. Atherosclerotic cardiovascular disease risk assessment is performed by the Cardiovascular Risk Calculator incorporating standard risk factors, and pharmacotherapy is implemented according to the algorithm for primary prevention. For patients on maintenance peritoneal dialysis or hemodialysis, the ASCVD experts felt that there was inadequate information to make a recommendation for or against the initiation or continuation of statin therapy. The next question reads, would this patient require treatment at this time? The 2013 KDIGO Clinical Practice Guideline for Lipid Management in Chronic Kidney Disease provides guidance on lipid management and treatment for all patients with chronic kidney disease, non-dialysis dependent, dialysis dependent, kidney transplant recipients, and children. According to KDIGO experts, in patients with chronic kidney disease who are non-dialysis dependent, the relationship between LDL cholesterol and atherosclerotic cardiovascular disease events is weaker than in the general population, likely related to the atherogenic dyslipidemia characteristic in chronic kidney disease. Thus, the measured LDL cholesterol does not serve as an indication for treatment. KDIGO guidelines recommend that lipid therapy be guided by the absolute risk of coronary events based on patient age and stage of chronic kidney disease or eGFR, regardless of baseline lipids. Statin or statin, ezetimibe therapy is recommended in non-dialysis dependent adults age equal to or above 50 years with eGFR 10% by the Framingham risk score. Statin therapy is also recommended in adult kidney transplant recipients. Therefore, according to KDIGO guidelines, SOW may be treated with statin or statin, ezetimibe therapy. The next question reads, MAT is a 56-year-old white female who presents for new patient evaluation with a 10-year history of type 2 diabetes mellitus and hypertension. Current medications include metformin, lisinopril, and chlorthalidone. She currently smokes about half a pack of cigarettes per day, but is considering a quit date. She reports that she struggles with weight management. Her BMI is 33.8 kg per meter squared, and has difficulty with exercise due to previous knee injury and a torn rotator cuff. She has a strong family history of premature atherosclerotic cardiovascular disease, diabetes, hyperlipidemia, and obesity. Her father underwent coronary artery bypass grafting at age 51. Her mother suffered a mild stroke at age 62, but has no residual deficits. She has 4 siblings of which 2 have known coronary heart disease. On physical exam her BP is 148 systolic 88 diastolic. She has bilateral carotid brutes. Cardiac exam is unremarkable. She has abdominal brute. Peripheral pulse is 1+ bilaterally. No tendon xanthomas, corneal arcus, or xanthelasmas. Her initial laboratory results demonstrate the following. Total cholesterol of 273 mg per deciliter. HDL cholesterol of 43 mg per deciliter. LDL cholesterol of 158 mg per deciliter. TGs of 360 mg per deciliter. Hemoglobin A1C of 8.2%. What are your initial recommendations for lipid management for MAT? All available guidelines for the management of dyslipidemia and diabetes recommend lifestyle counseling as the foundation of therapy. MAT's BMI is consistent with obesity and she has inadequately controlled diabetes and hypertension. Nutrition counseling and weight management will be critical to improve control of these important atherosclerotic cardiovascular disease risk factors. Tobacco cessation counseling, referral to a cessation program, and possible pharmacotherapy and/or nicotine replacement therapy are important in this very high-risk patient with a strong family history of premature atherosclerotic cardiovascular disease. Given the patient's ongoing knee and shoulder pain, her ability to engage in significant aerobic activity may be limited until successful weight loss is achieved. According to ACC, AHA, NLA, and ADA recommendations for management of dyslipidemia, MAT qualifies for statin therapy in a high-risk diabetic. Her 10-year atherosclerotic cardiovascular disease risk by the ACC/AHA cardiovascular risk calculator is 27.2% and high-intensity statin is indicated by the ACC/AHA treatment algorithm. Patients with diabetes and 2 or more other major atherosclerotic cardiovascular disease risk factors are considered to be at very high risk by the NLA, and lipid-lowering therapy is recommended with treatment goals of non-HDL cholesterol below 100 mg per deciliter and LDL cholesterol below 70 mg per deciliter. The ADA recommends statin therapy in all patients between the ages of 40 to 75 with type 1 or type 2 diabetes mellitus. The intensity of statin therapy is based upon the patient's 10-year atherosclerotic cardiovascular disease risk by the ACC/AHA cardiovascular risk calculator. High-intensity statin is considered reasonable in patients with 10-year risk equal to or greater than 7.5%. Thus, the recommendation for high-intensity statin therapy for MAT is consistent across all three of these U.S. guidelines. The next question reads, MAT is started on atorvastatin 40 mg but within the next 3 months returns to clinic complaining of joint and muscle symptoms, noting that her knees and shoulder are more painful. How would you approach the evaluation of possible statin-related muscle symptoms? Statin-related muscle symptoms present a significant challenge to clinicians, though the prevalence of true statin intolerance is likely quite low. A systematic approach to possible statin intolerance is required to confirm the diagnosis, particularly in a very high-risk patient like MAT. The ACC/AHA guideline and NLA recommendations provide similar strategies for patient evaluation and management, and these recommendations have been incorporated into the ACC Statin Intolerance app for all mobile devices as well as a web-based version. It is important for clinicians to take a careful musculoskeletal history and review of systems and document patient complaints prior to initiation of statin therapy. As reported by MAT, patients may report baseline muscle and joint symptoms that have varied in severity and frequency prior to lipid management. Following initiation of statin therapy, patients' muscle symptoms should be compared to those at baseline evaluation to determine if complaints are new or merely coincidental exacerbations of prior existing symptoms. True statin-related myalgias are typically symmetric and are described as aching, soreness, stiffness, tenderness, weakness, or cramping of large proximal muscle groups. Tingling, numbness, sharp or stabbing pain, twitching, nocturnal cramps, arthralgias, arthritis, or unilateral symptoms are less likely to be statin-related. Clinicians should consider factors that may increase the risk for statin-related muscle symptoms, such as heavy exercise or exertion, dehydration, substance abuse, frailty, low BMI, female gender, multiple or serious comorbidities, renal insufficiency, hepatic dysfunction, or drug interactions. Other potential primary causes of muscle symptoms should be evaluated, such as hypothyroidism, vitamin D deficiency, trauma, previous or new primary muscle diseases, rheumatologic disorders, metabolic disorders, adrenal insufficiency, hypoparathyroidism, Cushing syndrome, or peripheral arterial disease. The next question reads, what recommendations would you give the patient regarding continuation of statin therapy? The ACC/AHA and NLA recommend temporary discontinuation of statin when a patient reports muscle symptoms that they believe are related to treatment. Statin-related complaints usually resolve within a few days to 2 weeks, though there have been rare case reports of persistent myopathy following discontinuation of statin therapy. When symptoms have resolved and the patient is asymptomatic, treatment with the same statin at original or lower dose is reinitiated to determine if the symptoms are definitively related to statin. If muscle complaints recur, it is assumed that symptoms may be related to drug therapy and statin should be discontinued. Most algorithms for evaluation and management of possible statin intolerance recommend a trial of at least 2 to 3 statins with discontinuation and re-challenge if the patient again reports muscle-related symptoms. The 7 currently available statins differ in metabolism, half-life, and lipophilicity, and some providers recommend that the second or third statin prescribed in a patient with possible statin intolerance be chosen based on characteristics that differ from the initial agent. There is no trial evidence that this strategy is effective. There have been a number of smaller trials evaluating the potential benefits of ubiquinone or coenzyme Q10 in patients with possible statin-related muscle symptoms, but the results have been inconsistent. If a patient has failed a systematic challenge-re-challenge approach with 2 to 3 statins, guidelines suggest consideration of non-statin therapies such as ezetimibe, bile acid sequestrants abbreviated as BASs, or proprotein convertase subtilisin, kexin type 9 inhibitors abbreviated as PCKS9 inhibitors. Next we will discuss diabetes mellitus. Statins have been associated with an increased risk of type 2 diabetes mellitus. A review of 13 trials involving 19,140 patients showed a 9% relative increased risk for the incidence of diabetes in those taking statins compared to placebo. This equates to approximately 1 new case of diabetes for every 255 patients treated over a 4-year period. A meta-analysis of 5 trials comparing high-dose versus low-dose statins showed a 12% increased relative risk for incident diabetes over a 2 to 5 year follow-up in those patients who received higher doses of statins. Based on the data, there appears to be an increased risk of developing diabetes, albeit small. However, due to the demonstrated clinical benefit of statin therapy, the benefit clearly outweighs the risk of developing diabetes, and statin therapy should not be avoided due to the concern for this adverse effect. Overall, the incidence of adverse effects with statins varies, with myalgia being the most common. When choosing a statin as well as a statin dose, one must consider the various pharmacokinetic characteristics of that statin, the patient's comorbid conditions, and concomitant medications to minimize risk. We will briefly look at the place in therapy. Statins are considered first-line pharmacologic therapy for prevention of atherosclerotic cardiovascular disease events. They have demonstrated significant reductions in morbidity and mortality across many patient populations. Statin therapy should be initiated before or simultaneously with therapeutic lifestyle modifications. The initial dose of statin is determined by certain criteria that then place them into any of the 4 statin benefit groups. The criteria are based on age, presence or absence of atherosclerotic cardiovascular disease, presence or absence of diabetes, LDL cholesterol level, and their estimated risk based on the pooled cohort equation. High-intensity statin therapy is recommended in the following patient populations. Patients 190 mg per deciliter, or patients with diabetes mellitus type 1 or 2, between the ages of 40 and 75 with an estimated 10-year atherosclerotic cardiovascular disease risk of above 7.5%. Moderate intensity therapy is recommended in patients above 75 years of age if not a candidate for high intensity LDL cholesterol above 190 mg per deciliter, if not a candidate for high intensity type 1 or type 2 diabetes, and age 40 to 75 years, or a 10-year atherosclerotic cardiovascular disease risk of greater than 7.5% and age 40 to 75 years. A later population may be initiated on high-intensity therapy if clinically indicated. Of note, in patients with LDL cholesterol above 190 mg per deciliter, combination therapy with a non-statin agent may be needed to achieve additional LDL cholesterol lowering if desired. There are 2 patient populations for which there are limited data on the benefit of statin therapy. These include patients with atherosclerotic cardiovascular disease and heart failure, New York Heart Association Class 2 to 4, and patients on chronic hemodialysis. There are currently no recommendations to initiate statin therapy in these patient populations. In addition to their ability to lower LDL cholesterol, statin also have many pleiotropic effects that play a role in patients with atherosclerotic cardiovascular disease, independent of their ability to lower LDL cholesterol. These effects include improvement in endothelial function, plaque stabilization, antithrombotic effects, anti-inflammatory, antioxidant effects, increased nitric oxide bioavailability, and reduced plaque progression. Although well demonstrated as beneficial in patients with established coronary heart disease, this benefit in primary prevention is less well defined. In patients without coronary heart disease, statins have not been shown to reduce mortality. They have demonstrated a lowering of future vascular events over a time frame of 5 to 10 years, albeit small. As a result, prescribing statins in patients without atherosclerotic cardiovascular disease but who are between the ages 40 to 75 years with an estimated atherosclerotic cardiovascular disease risk of equal to or more than 7.5% remains controversial. We will briefly discuss drug interactions. Drug interactions with statins that result in higher blood levels of the statin or an active metabolite can increase the risk of myositis. Statins that depend on the cytochrome P450, that is the CYP3A4 enzyme system to be metabolized, are most vulnerable to this interaction, i.e., lovastatin, simvastatin, and to a lesser extent atorvastatin. Fluvastatin is primarily a substrate of the 2C9 isoenzyme and, to a lesser extent, 2C8 and 3A4 and, therefore, is more vulnerable to interactions with drugs that directly inhibit CYP2C9 or act as competitive inhibitors, that is, substrates, for this alternative system. Pravastatin, pitavastatin, and rosuvastatin are not extensively metabolized by the CYP enzyme system. Rosuvastatin is metabolized minimally, that is about 10%, with CYP2C9 and CYP2C19 being the primary isoenzymes involved. Pitavastatin is marginally metabolized by CYP2C9 and to a lesser extent by CYP2C8. A major metabolite in human plasma is lactone, which is formed via glucuronidation by uridine 5-diphosphoglucuronosyl transferases UGT-A3 and UGT2B7. Pravastatin undergoes isomerization in the gut to a relatively inactive metabolite. Variability of gastric metabolism has been shown to be associated with the LDL cholesterol-lowering effects of pravastatin. Therefore, rosuvastatin and pravastatin have the lowest potential for interaction with medications that inhibit the CYP metabolic pathways. Some of the most commonly encountered medications that interact with statins by inhibiting the CYP3A4 enzyme system are azole antifungals, itraconazole, ketoconazole, and meconazole, certain calcium channel blockers, such as diltiazem and verapamil, macrolide antibiotics, such as clarithromycin and erythromycin, protease inhibitors, e.g., ritonavir, grapefruit juice that is more than 1 quart, cyclosporine, and antidepressants, such as nifazodone. Drugs that are substrates for the CYP3A4 system include certain benzodiazepines, such as alprazolam, midazolam, and triazolam, calcium channel blockers, especially diltiazem, carbamazepine, cisapride, cyclosporine, estradiol, felodipine, loratadine, quinidine, and terfenadine. When these substrate drugs are used together with simvastatin or lovastatin, and to a lesser extent atorvastatin, systemic blood levels of the statin may be increased because of competitive inhibition of the CYP3A4 enzymes, and this may increase the risk for myositis. Added caution should also be exercised when adding gemfibrozil with a statin to treat patients who also have elevated triglyceride levels. Gemfibrozil interferes with the glucuronidation of statins, thereby interfering with their renal clearance. This impact may be minimal or up to a 3- to 4-fold increase in statin levels depending upon the specific agent. Due to the significance of this interaction, fenofibrate is the preferred fibric acid derivative to use in combination with statins. However, gemfibrozil may be used in combination with certain statins if clinically indicated. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 282.